Good morning, everybody. Happy Halloween. I see some awesome costumes out there. Some of you guys are as boring as I am, but many of you are much more exciting than me. I'm always reminded why I love working in a children's hospital on a day like today. So awesome costumes. We have two speakers this morning, Mariah Welch and Dr. David Notrika. Our first speaker will be Mariah Welch, who is a clinical nurse case manager here at Phoenix Children's, and she is in line to receive her doctorate in nursing practice, DNP, in December, so just in a month or two. The area of focus of her doctorate is provider knowledge of unintentional childhood injuries, and you all are going to participate in her doctorate project today. And so you have a little test in front of you, and Mariah will give you further explanation on what to do, but we hope that that's a great evaluation and learning process this morning. Our second speaker is Dr. David Notrika. Dr. Notrika needs no introduction. In this setting, he's been heavily involved in CME activities at PCH locally and nationally for many, many years. He's a pediatric surgeon here at Phoenix Children's who has been the trauma medical director at PCH since 2007. And he is a past president of the medical staff. So please welcome Mariah Welch.
Good morning. So like Dr. Olson had said, there is a pretest right in front of you. If you could just take a couple of minutes now, if you need a pen, Sharon in the back has one. Just fill out the pretest. There is also a disclosure statement at the beginning of it, so take your time now to just do that. You'll notice that there's a unique identifier, and I put an example at the top. You're going to use your first two letters of your first name, first two digits of your social security number. I promise I won't look into that. Year of high school graduation, and first two letters of your mother's maiden name. So that's an example right there that you can do. Also with that identifier, please put that not only on the pre-test, but also put that on the post-test, because after you're done with your pre-test, we're going to pass it to the ends of the table. I'm going to come by and collect it, and then at the end of everything, you guys will be able to have your post-test. Okay, for those of you who just walked in, I'm just going to go through the instructions again. In front of you, there is a disclosure statement, a pre-test, a post-test, and an evaluation form. Right now, if you guys could just open up your pre-test and fill it out, answer the questions that are there. Please make it a unique identifier. The instructions are at the top of the page as well as up on the screen, and make sure that you're putting both that pre-test identifier on your pre-test and as well as your post-test. And then we'll get started here in a second. Okay. So again, good morning. Happy Halloween. I'm loving the residents over there who are all dressed up. You guys look awesome. My name is Mariah Welch, and I am a clinical case manager here at PCH on Care Area 8, and I'm also a DMP PMP student at the University of Arizona. My project truly is focused on provider knowledge of unintentional childhood injuries, and that came from being a bedside nurse on Care Area 8, where the focus was trauma, and working with Dr. Natrika's amazing staff and team, and being able to take care of children who not all the time got the best education, and a lot of injuries happened. So this is where that project comes from. So some of the objectives that we're going to be talking about today is just understanding the clear definition of what an unintentional childhood injury is, describe the impetus for and the role of the CDC's Injury Prevention National Guideline, identify healthcare provider responsibilities regarding injury prevention, provide a synopsis of evidence regarding it, describe the prevalence of injury prevention, and describe ways that healthcare providers can impact the rate of those childhood injuries. So before I get started anywhere else, what exactly is an unintentional injury? What is an injury in general? So I can't talk about an unintentional injury without talking about what the definition of an injury is. And the definition of an injury is a body lesion at an organic level resulting from an acute exposure to energy in amounts that exceed the thresholds of physiological tolerance. So in regards to unintentional injuries for children, that's anything. That's falls, drownings, burns, suffocation, poisonings, anything and everything that could injure a child unintentionally. So what exactly does the CDC say? There's a lot, but the biggest thing was that unintentional childhood injuries are the leading cause of mortality and morbidity in children in the United States. And it is the leading cause of death in children over the age of 1 year old. In 2009, the Centers of Disease Control and Prevention on an injury prevention report showed that approximately 12,175 children ages 0 to 19 annually die from an unintentional childhood injury. Studies have shown that children are more likely to die before their first birthday, and it is one of the most under-recognized public health injuries today. So what else does the research say? Studies have found that there is an association between low socioeconomical statuses, Native American and Native Alaskan races, some children with ADHD and ADD. It also says that education and safety methods can be the leading change for 9.2 million children annually who are affected. Healthcare providers have an opportunity every single interaction with their patients to intervene, to promote safety, to talk about education with every single interaction. So as pediatric providers, what can we do? We can assess, we can identify, and we can implement interventions, all in order to impact the rates of unintentional injuries. So where exactly do we all fit in? Where do you fit in? Well, first, my question is, would unintentional injuries in children decrease if we as healthcare providers address the integral aspects of family environments, including their lifestyle and risk factors, with every single patient interaction? Of course, the answer is yes. Pediatric providers should include unintentional childhood injuries with every single interaction. So then why am I standing up here, and why are we having this issue? The studies indicate that injury is either not discussed or briefly covered. So what's the problem? Is there a lack of integration of knowledge? Is there a lack of provider knowledge? Or is there a lack of attention to childhood injuries? So here are some hard pills to swallow. One of my favorite research studies that I researched was in 2016 by McDonald and colleagues. He noted that research concluded that clinicians play a key role in promoting patient safety. The evidence was so strong with relationship to the provider and the injury that it showed that what was the focus? Prevention plus educational strategies equals a reduction in childhood injuries. So how is there still a problem? 60% of healthcare professionals know the term unintentional injury and know the term injury prevention, but only 25% of them understand that all children of all ages require education. And here's the hard part. 40% of them in that study stated injuries are not a priority for them. So that's not the case for all of us as pediatric providers, but this is still a really big issue. So what is some concrete evidence that we know? In 2014, a randomized controls trial called eHealth for You Home Safety was conducted, and it was amazing to be able to see it. There was a treatment group and there was a control group, and it was over a span of 6 months. The treatment group got web-based, in-depth, interactive, home-styled pediatric provider education, while the control group just got basic leaflets, basic handouts during their well baby visits. So what came from that study? The study showed that providers had positive feedbacks, that families had positive feedback, and they loved the educational models that they were a part of. They loved being able to have a web-based model that they could go to and that their provider would be able to show them. And an exponential difference in risk potential was seen due to the implemented provider-driven safety injury prevention within the home. So we can gather the information, we can gather the knowledge, but it's up to us as providers to implement it right away. So just a recap. The CDC reported in 2009 that 12,175 children, 0 to 19, die annually, that approximately 9.2 million children receive treatment in the emergency room, and I want to say half of them come here. Unintentional injuries in the home represent an important health issue. And here are some other facts. 30% of the 9 million children who experience an unintentional injury require hospitalization. And then as a case manager, childhood injury-related hospitalization cost $87 billion in medical and societal funds. Childhood injuries represent 40% of deaths among children ages 1 to 19. So we, as pediatric providers, truly can make a difference. Did you know there was a clinical practice guideline for this? I didn't know that until I did all this research. It's called Prevention Services for Children and Adolescents, and it was a proposed guideline for us as providers to be able to institute something within the home. The aim was to enhance the awareness of preventative services, recommend interventions that reduce unintentional injuries, and increase anticipatory guidance, while the goal was to provide age-appropriate recommendations to decrease childhood injuries. Did you also know there's a CDC National Practice Action Plan? Again, I didn't know that either. The CDC created a national action plan for children for children with injury prevention, and over 60% of stakeholders across the nation banded with the CDC to raise awareness, to highlight prevention, and to mobilize action on a national level. The project spanned over 18 months, and out of this project came something incredible. In April 2012, a roadmap to strengthen data surveillance, promote research, enhance communication, and improve educational training to reduce childhood injuries was established. And then from that, the American College of Preventive Medicine developed a childhood injury risk assessment tool in March 2014. Show of hands, who knew that assessment tool existed? That's why I'm here. So, what can we do? As pediatric providers, a majority of the preventative services happen and are centered around well child checks. There's nothing wrong with that. But truly, every single encounter that we have with our patients can make a difference, whether that's injury-related sick visit, whether it's a I have strep throat visit, whether it's anything. Anytime you interact with a patient, you have a chance to affect change in that family, and that patient, and specifically to help reduce injury prevention. So these guidelines are out here. They're recommended. They're there for screening maneuvers, counseling messages, specific interventions for children and adolescents. So what can you implement? Implement a web-based educational portal, age-appropriate anticipatory guidance handouts, safety screening tools to assess parental knowledge, because as the child grows, so does your education. And I know we all know this, but what is anticipatory guidance? It is given by the healthcare provider to assist parents and guardians in understanding the expected growth and development of the child. So when you're discussing the child getting ready to crawl, also throw in wall sockets, choking hazards, drowning prevention, and poisonous materials. It goes hand in hand every single time. And in 1983, the American Academy of Pediatrics introduced the TIP, the Injury Prevention Program, to encourage pediatric providers to effect change in injury prevention. TIP includes safety counseling schedules, age-appropriate safety surveys, and age-appropriate safety sheets that are incredible for families to be able to take home throughout their entire lifespan. So what can we do? We can make it fun. We can make it interactive. Utilize your patient portals within your primary care settings. If you don't have a portal, that's okay. Print it out. Attach it to every single one of their vaccination schedules. Attach telephone numbers. Make sure you have websites posted in your waiting rooms for them to see. And make it so that they don't have a question about anything that they're getting, that you can assess their knowledge every single visit, regardless of if it's a sick visit or a well visit. So, parents and children are often receptive regardless of the related visit. Parents want to learn, and we have to be willing to teach. So finally, pediatric providers can affect change and be advocates for injury prevention, kind of like how I'm standing up here today, and utilizing yourself and putting yourself in school systems, park districts, Head Start, child care centers, organizations like the YMCA, and then the local media. So lastly, this is probably one of my favorite slides because I actually used every single one of these. So yes, I ended up downloading this Elmo app on my phone. It was kind of funny. And I was able to look at it and utilize it and see how families could be able to use this and assess their knowledge. And although their child's not going to know what's going on, they're just going to see Elmo on their screen, they're going to be able to assess their knowledge, understanding that it's important for children to ride a certain way in their car seat. Down here at the bottom, along with that CDC National Action Plan, was the Color Me Safe coloring book. Yeah, moms and dads probably don't want to color, but it was really good for them to be able to have and to see and know that, okay, this cord is laying there, or hey, I probably shouldn't put poisonous materials in a place that the child can grab it. And then one of my favorite things in the world is in the top middle right here. This was on a primary care website. It is exactly what I just talked about. It's the TIP program. And it was so simple and so easy to see because I was able to grab safety sheets from 0 to 6 months, from 6 to 12 months, to 1 to 12 years. It was amazing. And then just those safety checklists that I was talking about, these are so simple to be able to print out for our families and just say, hey, I know that you have a brand new 6-month-old. I had an amazing well-child visit. We talked about a ton of injury prevention. Hey, take this home and just make sure that you have everything that it says on here. And if you need any tips or if you need anything, you can call me or shoot me a text in the portal. It makes it so easy and so interactive for our patients and our families, truly in order to affect change. So I just want to leave you with that piece as Dr. Natrika comes up to talk about some more unintentional childhood injury. And I just want to thank you, but I also want to ask you to just be on the side with me and with injury prevention with me and Dr. Natrika, and not the 40% of providers who say that it's not a priority for them.
So when Mariah asked me to speak, the first thing I did was say no, and if you've ever tried to say no to Mariah, it doesn't go so well. What you saw there was just a small modicum of her energy and enthusiasm. The reason that I tried to say no is because I'm a pediatric surgeon. I do trauma, and the reality is you guys are the ones who are already doing the anticipatory guidance. You're the ones who are counseling these families. And what she said to me was, well, you're the one who takes care of it when it doesn't work out. And so I'm going to talk to you a little bit about injury from my standpoint as the director of the trauma program at Phoenix Children's. My objective is to increase awareness of specific issues related to injury and provide a little bit of targeted education. We can't talk about everything, but just a few things that are important to me. We'll go over a little bit about the demographics of injury. We'll talk about fatal injury and non-fatal injuries and preventable injuries, child maltreatment, dog bites, and then you'll finish up your post-test. Hopefully you will have learned something. In Arizona, about 39% of the injuries, 39% of the deaths that we see are actually preventable deaths. And that data comes from something that we do every year with the state of Arizona called the Arizona Child Fatality Review Program. And members of Phoenix Children's participate in that review. And they look at every child that died in Arizona. And there are a lot of child deaths. And so this is basically children under 18 years of age. Luckily, the number from last year's number, which is the 2015 number, decreased from about 180 deaths to about 160. The leading cause was suffocation. One of the things that we still find amazing is that African Americans and American Indians are still disproportionately represented across all categories. And whites and non-Hispanic children comprise a higher percentage of suicides, drownings, and firearm injuries. And that's important to take race into consideration when you're doing your anticipatory guidance. When you look at this number, African Americans in our community in Arizona represent about 6% of the population, but about 9% of the fatalities. And so they have a disproportionate burden of death. For American Indians, it's even worse, and so they're 5% of the population and 9% of the mortalities. Being Asian is protective. Hispanics are about neutral, and being white and non-Hispanic is somewhat protective. We talked a little bit about the leading causes of accidental injury or unintentional injury, and suffocation is certainly the leading cause in the children that die in Arizona. We had 63 deaths in 2015. Motor vehicle collisions are second, and obviously we still have a problem with drownings. When you go beyond just the accidental injuries and look at all intents, you can't miss the fact that child maltreatment is at the top of the list. And so 87 deaths in 2015 from child maltreatment, and that was up 15% from the year before, and all of those are preventable. Of course, SIDS and motor vehicle collisions make up a good portion of deaths as well, and then you get to suicides and homicides and drownings and firearms. But we have a pretty significant problem. At Phoenix Children's, we do about 300 evaluations a year for child abuse. So that's about one a day. And I'll tell you, every time that I tell people who are not in the medical community that we do that many evaluations, they are just shocked that we do one every day. People can't wrap their head around the fact of how common it is to have child maltreatment. Of those 300 patients, about 78% of them are ultimately deemed probable abuse. And 78% of them are kids that are under 2 years of age, so under 24 months of age. And so we know what kids we need to target, which ones are at the most risk. Talking of risk, the factors that we associate with child maltreatment, we looked at our numbers here at Phoenix Children's. Prior CPS involvement is certainly a big risk factor, but it's only about 27% of patients. Prior police records from the caregivers is also a big one. So, parents who have had brushes with the law are certainly at more risk of injuring their children. Intimate partner violence is intimately associated with child maltreatment. We used to call it domestic violence, but intimate partner violence is a big deal. Other risk factors that you may not think about and that we weren't aware of before the study were kindred care. So, being taken care of by a family member who is not mom or dad is a risk factor for child abuse. Prematurity and twin gestation are mild risk factors, and then being on public insurance is also a factor. When you're looking at the history, when you see children with injuries without explanations, that's certainly a big red flag for child maltreatment. Inconsistent explanations, delays in seeking care, injuries that should result in a call to 911 that instead come to your office the next day are certainly at higher risk. It's amazing how consistent not calling EMS is when it comes to child maltreatment. So there are a variety of reasons that we speculate that these patients arrive not by ambulance. I think a lot of it has to do with if they don't want EMS looking at the crime scene or gathering evidence. I think a lot of it has to do with that they delay seeking care, and so by that point they just drive the kids in. Also, we see a lot of explanations inconsistent with developmental age. My 2-week-old rolled off the bed. 2-week-olds don't roll. At Phoenix Children's, along with the forensics team, we've done a lot of work on discovering biases in the evaluation for child abuse. And so you think at Phoenix Children's, where we are so attuned to it and so aware of it, that it wouldn't be the case. But the truth is that we work up patients for child abuse differentially based on whether or not the families are together. Based on what socioeconomic status they are. And really, that's not the way to do it. You really need to have a very defined algorithm for who gets worked up for child maltreatment. And so in the next phase, we actually implemented a screening program where we said, all right, all the kids that have this are going to get a workup for child maltreatment. And I will tell you that it was an epic failure. And so we learned a lot in the process, but the truth is, it is very hard to change provider attitudes and biases when it comes to child maltreatment. What you really need to understand, though, is that children across the board are potentially affected by child abuse, and you just have to keep an open eye and an open mind when you talk to these families and see these children. Mariah spoke briefly about the CDC, and the CDC technical package was, every time the CDC puts its effort behind things, it's kind of a big deal. And what they came up with the CDC technical package was 5 strategies. And I'm not going to go through all of them, but I'll tell you that one aspect of it to intervene to lessen harms and prevent future risk was enhanced primary care, was really exactly what Mariah was talking about. And and also the implementation of behavioral parenting programs. So Safe Kids is an example of one. How many of you guys are familiar with Safe Kids? Couple? Okay. How many of you guys are familiar with Triple P? Okay. So, Safe Care is an in-home parenting program that really kind of targets the parents of children 0 to 5 years of age, and with risk factors for neglect or abuse. And and it provides information on how to interact in a positive manner with children, how to plan activities, how to respond appropriately to challenging children behavior. When you guys are in the office, how much time do you spend telling your parents how to deal with a child who is exhibiting a challenging behavior? Yeah, it's important and it's not fun, but the parents need that. And I think there's a lot of times we assume that parents know that, or especially if it's a second child. Maybe that first child was incredibly easy, but you need to make sure you incorporate that into your anticipatory guidance. And then the program does other things. Regarding recognizing hazards at home, we looked at a study where we were, Dr. Sayers in the back, and I looked at a study where we were trying to figure out about how to better identify child abuse. And when you have these injured kids and you compare them, you realize that there's child abuse, but there's also a tremendous amount of neglectful parenting that results in injury as well. And matter of fact, the two groups don't look that different. So you've got people who actually beat their kids and people who ignore their kids, and they're not that different in their patterns of injury and their utilization of the emergency department. And this program kind of addresses both. And it also talks about recognizing responding to symptoms of illness or injury. And the reason that's important is that these are stressors. Now, when we see child abuse, one of the things that struck us is how often the children had colds, because we would go on rounds, and every time that we go into a kid that was child abuse, we'd have to put on the yellow gowns. And we're like, what is going on? Why do we always have to put on a yellow gown when we go at a kid who's got basically a broken arm? And the reality is that those kids were sick, and that was a stressor that affected them. And so, yeah, it's important to help the family with taking care of illness, regular routine illness. So in order to do good anticipatory guidance, you have to understand a bit about what is killing kids. And so this is some data that was provided to me by Angelica Baker in the Injury Prevention Program. And you'll notice that in the first 27 days of life, you're not seeing much in the way of preventable injuries. So the preventable injuries are in blue colors. But you start to see suffocation as a big injury factor in that first month to first year of life, and then in the next phase from 1 to 4 years, that's when you get your drowning injuries, and you first start to see motor vehicle injury as being a major mechanism. As you move up to the 5 to 9 year old school age kids, motor vehicle collisions become a bigger deal. Certainly drownings are a big deal at every age. And then as they get older, you begin seeing motor vehicle collisions, firearm accidents, and then, of course, that last part, that difficult years when you see more firearm injuries. Children start driving or driving with their friends in motor vehicle collisions, hangings and poisonings. When it comes to suffocation, the new terminology is sudden unexplained infant death, and SIDS is a portion of that. A lot of these deaths are potentially preventable simply by discussing safe sleep with your kids. And I know all the pediatricians in the room know that, but the question is, do your parents know that, and are you able to provide guidance to your kids? This is just a standard, advisory thing, talking about what is a safe sleep environment. The irony is, at Phoenix Children's about 3 years ago, if you went to the NICU or went to our areas, we did not have safe sleep environments here in the hospital. I mean, there were Beanie Babies that could smother a child. There were mattresses that did not fit appropriately in the cribs, and it was just an absolute horror show for our injury prevention team, who is spending so much time teaching parents how to do this at home. but the hospital wasn't setting a good example, and we made a big effort to improve the safe sleep environment at Phoenix Children's, but I need you guys to make sure that you're covering that with your families as well. I thought that this slide was interesting, but these are absolute deaths, and this is Arizona only. And the scale is not, the bottom scale is not to scale, but it kind of shows when the deaths are happening. And so, the first 27, there's not a whole lot of stuff that we can do for most of these kids. These are not accidental injuries. A lot of these are congenital injuries during the first year. But as we get further on, the children actually get safer, and we have fewer kids dying in these 5 to 9 and 10 to 14 years. And so you're talking about 50 deaths a year in those age groups. That's still a lot, don't get me wrong. This is just for one relatively moderate-sized state. But then we spike again as we get to the older kids. When we look at non-fatal injuries, and this is U.S. data, not Arizona data, falls certainly are the leading cause, and then being struck by or struck against. This includes your furniture tip over accidents, the standard flat screen that falls on the kid's head, or the all that entire untethered furniture aspect that are so dangerous for kids. There's also a surprising number of kids that are cut and pierced. And when we looked at the data at Phoenix Children's, we have a moderate amount of vascular injuries that occur from glass. And so glass and mirrors, children that break glass that are not safety glass, that then go on to have major vascular injuries that have to be repaired. This is data from Phoenix Children's Hospital. So this is just hospital data, 2015 data. When we look at falls, again, it's our number one mechanism, but it's not the number one thing that kills kids. That child abuse is still the number one thing that kills kids. Motor vehicle collisions makes up a large portion of the patients that we see, as does being struck by objects. Firearm injuries are surprisingly small in Arizona. That gets a lot of talk. I'm not mitigating the impact of firearms, but when you look at the whole picture, it's not as big a piece of the pie as a lot of the other things that we see. The thing that I found most striking were really the animal bite injuries. And when we when we see animal bite injuries in the trauma program, they're a little bit different than what you're seeing in your office. Apparently it's not.
The right eye is completely avulsed from the medial canthal tendon with a tear inferiorly along the lower eyelid and superiorly across the upper eyelid, extending through the conjunctiva. The left eyelid is also lacerated through the superior canaliculus and full thickness laceration. And then I'll let you pick up with the rest.
So our version of dog bites may be a little different than what you guys are seeing in the office. When you look at what aspects of the body dogs attack, I think that this graph kind of shows that things change. So when you're talking about the kids that are 0 to 4 years of age, the head and neck is the main area of the body that gets attacked. And then as they get older, this number drops. And by the time that they are teenagers, it's not the head that's being attacked anymore. Then you start seeing more of this arm and hand injury. So they're reaching to pet a dog and they get bit by a dog. And I think that there are a lot of reasons for those changes. But a lot of it has to do with the fact that parents don't realize that their small children don't recognize the signs that a dog is getting ready to bite. And so you can't teach a 1-year-old or a 2-year-old what those signs are, but you can teach the parents, and that needs to be part of your anticipatory guidance so the parents know what to look for. There's a lot of great information out there on preventing dog bites. I'm a dog lover. I had 3. I've got 2 now, and and this stuff is really important so that we keep the kids safe. And the information's out there. You can teach parents about canine body language and about dog prevention. I love the doggy language. It's not very helpful, but it's absolutely adorable. And this one I thought was really telling. So this one, it says, I think this picture looks cute. And I love this picture because what it shows is a child who's doing something that children do, face to face with that dog. But that dog has a wide-eyed stare. The ears are pulled back, furrowed brow, a tense, tightly closed jaw, and a stiffened posture. This is not a dog who is getting ready to roll over and get petted. This is a dog who really is showing a lot of behaviors that should be warning signs for parents. We spend very little money on injury prevention. You as pediatricians don't get paid nearly enough for the time that you spent doing anticipatory guidance. Dwayne Woon gets paid even less than the rest of you in the room for anticipatory guidance. But the return on investment's really high. And so when we talk about things like child-proof lighters, which basically saves $72 for every dollar spent on child-proofing lighters, and booster seats, which saves about $71 per booster seat, that's a huge return on investment. But pediatrician counseling is not as significant. For every $1 that's spent on counseling, for every $1 spent on counseling, you get about $9 back in savings to society. And so the time that you spend counseling for parents really has a ninefold increase. I would love to see that, the amount of money that pediatricians get paid for anticipatory guidance, skyrocket. One of the things that we were told when this new healthcare system came along was that all of this excellent care was going to lower the cost of health care and make it affordable. And it's funny because when I think about getting cancer, you're not going to prevent cancer, childhood cancer, even adult cancer very well. Where's all that coming from? There's only one place that you can actually make a huge difference in the healthcare system, and that's with trauma and injury. Trauma and injury is really expensive. It's really expensive in the number of active live years lost, but it's really expensive in the amount of money that we spend taking care of people who are injured. The only place where you're ever going to be able to save money is through injury prevention, and that's adult and pediatric. When we talk about the basics of injury prevention, injuries are not accidents. They are preventable. They're often understandable, predictable, and preventable. And you just need to start analyzing the circumstances that brought about those injuries, and I think that's important. Strategies for prevention. We talk about intervening and doing countermeasures and changing behavior. And there are two types. There's the active type where we rely on actions of the individuals, but there's also the second type, which is passive, which don't rely on the efforts of an individual. So things like safety lids, things like car seats that are automatic, things that are part of the built environment that help make kids safer. When it comes to injury prevention, there's the 3 E's: engineering, environmental change, and education. And the part that we're looking for the pediatricians to change is that third part, that education. So how do we do it? Well, I think Mariah already told you that part. And so with that, I'd like to thank Angelica Baker for her help, and appreciate the opportunity to talk with you a little bit about injury prevention from my standpoint. Thank you.
Work on your post-test for me, making sure that identifier is at the top of that page as well. But honestly, we both thank you so much. Injury prevention is such an important topic. Like Dr. Natrika said, it's something that truly can affect change in our Affordable Care Insurance Act. I don't know what we want to call it anymore. But we just thank you, and we open it up to questions while you guys are completing your post-test survey. Dr. Schindel?
With regard to injury prevention, one thing I
Well, it's funny because Arizonans are notorious because they don't want you to take away their guns, but they don't want you to take away their trampolines either. And I had a patient who came in and had a grade 3 splenic injury from a trampoline, and the family asked when their child could be back on the trampoline again. And I told them never, and they thought I was joking. And I'm like, no, you're asking me when I get permission to be back on the trampoline? Never. So you're going to do it anyway, but no, I'm not going to tell you it's okay to go back on a trampoline. It's just, no, it's not safe. So. Mhm. Yeah. No, you're absolutely right. The Consumer Product Safety Commission doesn't seem to want to take on trampolines. They'll take on a bed that collapses and suffocates a kid, but trying to get them to take away recreational things that have inherent risk, they've been less willing to take on products that are not defective, but are similarly dangerous. If you really want to get in hot water, try and tackle the cubic centimeters or the engine size of ATVs, because the reality is that these companies are selling very high-powered ATVs, and children get on them, and their response is, well, children are not supposed to be on them, but the reality is children are on these ATVs, and there is a relationship between the engine size and the ATV. The bigger ATVs do cause more accidents, and we saw a big spike when the legislation limiting ATV engine size in Arizona expired about 10 years ago. We're constantly seeing ATV injuries, and that's a lot of extremity injuries, because what happens with ATVs is the teenager, it starts to tip over. These ATVs weigh a ton. They put their arms out, and then they tip over, and then they break their arm. Or the ones that have the roll bars, they put their arms out like this, and the roll bar then crushes their hands. In answer to your question, nothing. Other questions?
What anticipatory guidance do you give about dogs? I get these forwarded emails with these darling pictures of babies, and I realize you have the dog language and all that. Personally, I'd rather people just not have dogs. That's what I'm gonna ask.
No, and so the number one breed of dog that causes bites is actually golden retrievers, which are the most docile dogs in the world. And the reality is that most of those bites are not serious. They're not maulings, but they are bites, and most of it is around food aversions or food protection. And so you need to incorporate that in. I thought that one of the better ones was this one, which basically just some basic stuff about not approaching unfamiliar dogs. Don't run and scream from a dog. Remain motionless. If knocked over by a dog, hold still. Children should not play unsupervised with a dog. As a matter of fact, a tremendous amount of the injuries that we've had have resulted from dogs and children interacting in unsupervised environments. We had a child who was castrated by a pit bull, and mom was either not in the house or using drugs at the time, there's good information out there on anticipatory guidance for dogs. A lot of it is actually put out by the dog lovers, and it's because they want the kids to be safe around dogs. So. And it's possible to create a safe environment for dogs and children.
And on that aspect of like primary care, it's asking those simple questions. Do you have a dog in a home? Does grandma have a dog? What kind of environments do you guys open yourself up to? Assessing those things and then leading into that. It's all about just asking the right questions and taking the time to ask the right question. Dr. Wooten? Absolutely. Right, absolutely.
But but their neighbors do, right?
Yes.
A lot of people don't understand that.
Absolutely.
That is,
Especially at this stage.
Absolutely.
that is so important.
Yeah.
I really like the checklist idea with the
Yeah.
measures and different features.
Mhm.
I don't think we have anything like that in the clinic right now, but I think it's pretty helpful because
Absolutely.
we have a whole wall of handouts.
Yeah.
Or wall health visits, plastic visits, and no big deal. I think that would be really helpful to have because honestly, a lot of it comes down to time.
Absolutely.
It's like short visits, and I always try to talk about sleep and a couple different things.
Mhm.
But to be able to give them there something where you can go over it and go home and
Yeah.
over those things without being there touching them.
Yes. Absolutely.
Yeah.
Yeah, and truly, it's already developed. It's the TIP program, and it's kind of blanket out there for you. So ages 0 to 6 months, 6 to 12 months, 1 year to 5 years. It's kind of just out there, and it's printable.
So we should just be using that one.
I think it's a great tool. If us as like a hospital system want to create something like that for the clinic, I think that's a wonderful idea. But for sure, there are tools already available.
And I'll tell you, I would for the clinic, I'd also ask you to reach out to Angelica. They're doing injury prevention. They would love to partner with the clinic. They love to partner because there's only so much teaching that they can do, and so and they can help you get great resources, including resources both here at the hospital and the CDC resources, AAP resources. There's a lot of stuff out there, and they'll help you cull through that.
Any other questions? No? Thank you so much.